Good morning, good afternoon, and good evening, wherever you may be in the world. On behalf of the International Society for Diseases of the Esophagus, I would like to welcome you and thank you for joining us for today's virtual presentation. The ISDE's mission is to promote the exchange of scientific and medical knowledge of the esophagus among specialists in the field, and we're happy to bring you this virtual presentation and discussion entitled Functional Heartburn and Reflux Hypersensitivity, Commonly Encountered but Often Overlooked. I'm Brad Kendall. I'm a gastroenterologist at the University of Queensland and Princess Alexandra Hospital in Brisbane, Australia, and will be moderating today's session. We're very fortunate to have two outstanding speakers for today's presentation, Dr. Ronnie Fass, Medical Director from the Digestive Health Center in Cleveland, Ohio, and Dr. Joan Chen, Assistant Professor at the University of Michigan in the US. The format of today's webinar will include a presentation on functional heartburn and reflux sensitivity, followed by two cases for discussion, followed by a panel discussion. We'd like to make this presentation as interactive as possible, and there will be audience polls throughout the webinar, and we encourage you to ask questions at any time in the Q&A section of the Zoom, not the chat, but the Q&A section, and we'll try and get through as many questions as we can in the last 10 minutes of the session. Our first speaker will be Professor Ronnie Fass, who I'm sure is well known to many of you in the attendees. Professor Fass is the Medical Director of the Digestive Health Center, Chairman of the Division of Gastroenterology and Hepatology, and Head of the Esophageal and Swallowing Program at the Metro Health Medical Center, Cleveland, Ohio. He's also a tenured Professor of Medicine at Case Western Reserve University, and Professor Fass has published more than 450 articles, editorials, and commentaries, and is the author of many of the landmark papers on today's topics. He's also been a core member of multiple consensus guidelines on esophageal disease and has served as a member of many committees in different GI societies around the world. He's currently the editor-in-chief of both the Journal of Clinical Gastroenterology and the editor-in-chief of the Journal of Neurogastroenterology and Motility. It's a great pleasure that I welcome Professor Fass to the virtual podium for his presentation. Ronnie, the screen is over to you.
Thank you very much, Bradley. It's a great pleasure and a great honor to be here today. And thank you all for tuning in. So the topic today, which is obviously very dear to me, is very important because I will try to cover the issue of two important functional esophageal disorders that are very common, often overlooked, and have a very important impact on diagnosis and management of gastroesophageal reflux disease. So first of all, let's understand a little bit what are reflux hypersensitivity and functional heartburn. So when we look at the functional esophageal disorders, we know that there are 5 of them: functional chest pain, functional dysphagia, globus, functional heartburn, and reflux hypersensitivity. Now, what's unique here with these two functional esophageal disorders is the fact that heartburn is the predominant symptom of both disorders. Now, this is something really unique to Rome 4. Previously, we didn't have any two functional esophageal disorders with the same predominant symptom. Now, functional esophageal disorders, they come under the category of disorders of gut-brain interaction. And functional esophageal disorders are considered to be chronic esophageal symptoms in the absence of identifiable structural, inflammatory, motor, or metabolic mechanisms as the etiology. Functional heartburn has been defined as burning retrostellar discomfort or pain, no symptom relief despite optimal anti-secretory therapy, the absence of evidence of gastroesophageal reflux or reflux disease, lack of evidence of abnormal esophageal acid exposure, and or symptom reflux association, or the presence of eosinophilic esophagitis as the cause of symptoms. Also, there should be absence of evidence of any major esophageal motor disorder, including achalasia, EGG outflow obstruction, as well as others that are mentioned on the slide. Now, the criteria must be fulfilled for the past 3 months with symptom onset at least 6 months before diagnosis, and the frequency has been determined to be at least twice a week. Now, reflux hypersensitivity was introduced for the first time by Rome 4, although the whole topic of reflux hypersensitivity was known to us for decades before it was recognized as a separate functional esophageal disorders. It was termed, and you can still find it in the literature, as hypersensitive esophagus. It's just that Rome 4 changed the term, the name, to reflux hypersensitivity. So it is retrosternal symptoms, including heartburn and chest pain. Patients should have normal endoscopy and absence of evidence, again, that eosinophilic esophagitis is the cause of symptoms. There should be also absence of major esophageal motor disorders, like what I mentioned, achalasia, distal esophageal spasm, and others that I mentioned on the slide. Now, the last point is very important. This is truly characterized reflux hypersensitivity. Evidence of triggering of symptoms by reflux events, despite normal acid exposure on pH or pH impedance monitoring and response to anti-secretory therapy, does not exclude a diagnosis. So it's very important to understand that it could be any type of reflux that can trigger symptoms. It could be acidic or non-acidic, but it has to be within the context of normal esophageal acid exposure. If the patient has abnormal non-acidic reflux in the background, that does not exclude reflux hypersensitivity. And then criteria must be fulfilled for the past 3 months with symptom onset at least 6 months before diagnosis with a frequency of at least twice a week. Now, obviously, when we talk about diseases that present as normal endoscopy and heartburn, then we're looking at 3 major esophageal disorders. We're looking at functional heartburn, reflux hypersensitivity, and non-erosive reflux disease. The distribution of these 3 amongst patients with heartburn and normal endoscopy is as follows, as you can see on the slide. Only half of them have gastroesophageal reflux disease in the form of non-erosive reflux disease. 20% will have reflux hypersensitivity, and 30% will have functional heartburn. So clearly suggesting that the 2 esophageal disorders are very common. Now let's get even a 30,000 a high look at the prevalence of functional heartburn and reflux hypersensitivity among patients presenting with heartburn. So if you take patients present with heartburn and they undergo an upper endoscopy, about 30% of them will have erosive esophagitis, 70% will have a normal endoscopy. If these patients that had a normal endoscopy undergo pH testing, then about half of them will have an abnormal pH test, thus they fall under the category of non-erosive reflux disease, and another half will have a normal pH test. And when we take those with normal pH test, about 40% of them will have a positive association with reflux events. So they have a positive symptom indices. These are the patients with reflux hypersensitivity. And overall, they account for about 14% of these heartburn patients that presented to our office. Now, 60% of the patients with normal pH tests will demonstrate no relationship between their symptoms and reflux events. These are the patients that fall under the category of functional heartburn. They account for 21% of all patients that present with heartburn. Now, if you combine the 2, you will see that 35% of patients that present with heartburn, about a third of the patients, have a functional esophageal disorder. And that's very important to understand because for decades, these patients reflux hypersensitivity and functional heartburn were not excluded, for example, from pivotal trials that evaluated the value of proton pump inhibitors in patients with non-erosive reflux disease. And obviously, they had a tremendous impact on the response rate that was reported in this study, because as one would expect, these patients had a low response to anti-reflux medication, specifically to proton pump inhibitors. Now, we have to take into account this new consensus that has been introduced to us about 3 years ago called the Lyon consensus. This consensus meeting of experts in the field of gastroesophageal reflux disease came up with metrics for diagnosing gastroesophageal reflux disease. And they made very important decisions that may have an impact on how vast and big are functional esophageal disorders as compared, for example, to non-erosive reflux disease. Now, for example, when we look at the top of the slide where it says conclusive evidence for pathologic reflux, one can see under endoscopy the presence of Los Angeles grade C and D, long segment Barrett's mucosa, and peptic esophageal stricture. In the case of normal endoscopy, then the Lyon consensus recommended as conclusive evidence is pH or pH impedance with acid exposure time that is greater than 6%. Now, when we look underneath, Los Angeles grades A and B esophagitis are considered by the Lyon consensus meeting as borderline or inconclusive evidence. Furthermore, if you look at the pH impedance, acid exposure time between 4 and 6% falls under the category of borderline or inconclusive evidence. That means that now the threshold to make diagnosis of non-erosive reflux disease is much higher than it was before the Lyon consensus meeting. That suggests that maybe the percentage of functional esophageal disorders, it's much greater than what I said so far, which was based on the diagnosis of non-erosive reflux disease before the Lyon consensus meeting. Now, I do have some problems with the Lyon consensus meeting. For example, they're called that grade B erosive esophagitis is inconclusive. This is a patient, one of my patients. The patient has grade B erosive esophagitis. I doubt that any one of you would argue that the patient does not have erosive esophagitis or gastroesophageal reflux disease. However, I do agree with grade A erosive esophagitis. I think grade A erosive esophagitis is a finding that may or may not be associated with gastroesophageal reflux disease. And many studies have shown that the reliability of this finding is not high. So, moving on from Lyon consensus meeting, let's talk a little bit about heartburn. So I'm going to make a few statements that will help us to provide the background for these very important functional esophageal disorders. The first one, esophageal symptoms are not stimulus specific. Now that's very important to understand because for decades we thought, for example, that only acid can result in heartburn and that heartburn can result only from acid. So now we know that this concept is obsolete because not only acid can lead to heartburn and not only heartburn can result from acid. Different types of symptoms may be generated by the same stimulus, even in the same patient. So one can have different types of symptoms, let's say chest pain and heartburn, and they can be caused by the same stimulus, which is acid reflux. And it can happen even in the same patient. We do know that some of the non-cardiac chest pain patients may have reflux causing them their chest pain at one time and then heartburn at other times. Heartburn can result from different intraesophageal stimuli. So studies have shown that acid reflux, so chemical stimuli, mechanical stimuli, thermal stimuli, electrical stimuli, all in the esophagus can lead to the same symptom, which is heartburn. But at the end of the day, the esophagus has a very limited repertoire of symptoms. So the whole concepts that symptoms are stimulus specific, I think from the beginning, did not really meet our clinical experience. Functional esophageal disorders can present solely with heartburn, which is indistinguishable from the heartburn reported by all phenotypes of gastroesophageal reflux disease, including non-erosive reflux disease. And it doesn't matter if you assess frequency of symptoms, severity of symptoms, or duration of symptoms. None of them can distinguish among any of the GERD phenotypes or these two functional esophageal disorders. Now, when we look at the hierarchy of response to PPI treatment, and this is in patients with heartburn and normal endoscopy, obviously those with non-erosive reflux disease have the highest response rate. In fact, if you take patients with non-erosive reflux disease and you study to make sure that they all have abnormal esophageal acid exposure, then their response rate to anti-reflux medication may be as close as you see in patients with erosive esophagitis. Patients with reflux hypersensitivity do have some level of response to anti-reflux medications, primarily PPIs, and functional heartburn patients do not demonstrate any evidence of response to anti-reflux treatment. In relation to underlying mechanism, the best example really comes from this figure that we developed for ROM4. Now, if you look on the left side, you will see the two GERD phenotypes, erosive esophagitis and non-erosive reflux disease. If you look at the right side, you will see the two functional esophageal disorders, reflux hypersensitivity and functional heartburn. In the case of erosive esophagitis, you can see that acid exposure is the predominant underlying mechanism. When you look at non-erosive reflux disease, acid exposure remained the most important underlying mechanism in triggering symptoms, but you started to see the importance of esophageal hypersensitivity as another underlying mechanism for symptom generation in patients with non-erosive reflux disease. When you move to reflux hypersensitivity, then esophageal hypersensitivity becomes the predominant underlying mechanism, but still acid reflux does play a role in symptom generation in this patient population. And in functional heartburn, it's primarily esophageal hypersensitivity as the underlying cause. So I think that kind of figure gives you an idea about the role of acid exposure and esophageal hypersensitivity in symptom generation of these patients. So what is esophageal hypersensitivity? And by the way, esophageal hypersensitivity is the underlying mechanism for all functional esophageal disorders. So not only functional heartburn or reflux hypersensitivity, it's also the underlying mechanism of functional dysphagia, globus, functional chest pain. So it's the perception of non-painful esophageal stimulus as being painful, what we call allodynia, and normally painful esophageal stimulus as being more painful than usual, and this is what we call hyperalgesia. So this is esophageal hypersensitivity. It is associated with lower perception thresholds for pain that can be seen in these patients. Okay, so let's move on and look again at functional heartburn reflux hypersensitivity, and another important contribution that came from ROM4 in understanding these two functional esophageal disorders. So obviously you can have patients who just have functional heartburn, they have reflux hypersensitivity, so they have one of those, and that's what they have. But then you can have patients with documented gastroesophageal reflux disease. Patients, for example, with evidence in the past of erosive esophagitis or somebody did a pH test or pH impedance demonstrating abnormal esophageal acid exposure. So these patients clearly have gastroesophageal reflux disease. However, because they do not respond to anti-reflux treatment, they fall under the category of refractory GERD. Studies are done, and then these patients are found to have either functional heartburn or reflux hypersensitivity. Now, because the patient is known to have gastroesophageal reflux disease, then we say that these patients have functional heartburn that overlaps with gastroesophageal reflux disease, or reflux hypersensitivity that overlaps with gastroesophageal reflux disease. And likely that these functional esophageal disorders are driving patients' residual symptoms. So it's very important to distinguish between these two clinical scenarios of the patient with just these functional esophageal disorders or patient with gastroesophageal reflux disease that also harbor these disorders. So how do we make the diagnosis of non-erosive reflux disease, functional heartburn, and reflux hypersensitivity in patients with recurrent heartburn despite PPI therapy, but with no evidence, previous evidence of gastroesophageal reflux disease? So all these patients should undergo an upper endoscopy, and if it's negative, biopsies should be taken to exclude eosinophilic esophagitis. If the test is abnormal, obviously, whatever the finding should be addressed. If the test is normal, then reflux testing is recommended at this juncture, and it should be done off PPI therapy because the patient is not known to have gastroesophageal reflux disease. If the patient has excessive acid exposure time, then you got your non-erosive reflux disease patient. If the patient does not have it, then you look at symptom association. You have to perform also high-resolution esophageal manometry to exclude major esophageal motor disorder, as was recommended in my definition. If there is positive association between symptoms and acid reflux events, and you got reflux hypersensitivity. If it's negative, then you got functional heartburn. So this is how you make the diagnosis. Now, what about patients with recurrent heartburn despite PPI therapy, but with previously established gastroesophageal reflux disease? Again, these patients should undergo also upper endoscopy. If negative, biopsy should be done to exclude eosinophilic esophagitis. Then if the upper endoscopy and the biopsies are unremarkable, then the patient should undergo pH impedance testing on PPI treatment, because we do know that the patient has gastroesophageal reflux disease. If for some reason the patient still has excessive acid exposure time, then you got patient with gastroesophageal reflux disease. If the patient has normal esophageal acid exposure time, then you look at symptom association. Again, you have to exclude major esophageal motor disorder. And if it's positive, you got reflux hypersensitivity. And if it's negative, you got functional heartburn. But because the patient is known to have gastroesophageal reflux disease, both of them will be considered as overlapping with gastroesophageal reflux disease. There are other ways to make the diagnosis of functional heartburn, trying to exclude normal subjects or those with non-erosive reflux disease, those people that might have normal endoscopy, not so much looking at reflux hypersensitivity. This is, for example, using biopsies and then histopathological analysis, looking at all the typical histopathology of gastroesophageal reflux disease, like papillary elongation, basal cell hyperplasia, dilated intercellular spaces, and others. And in fact, at the end, you can have a histomorphological sum score, and you can use that to differentiate between gastroesophageal reflux disease and your functional heartburn patient. Again, as I mentioned, no studies in this arena that looked at reflux hypersensitivity. You can use impedance pH metrics to identify patient with functional heartburn and reflux hypersensitivity. Here in this study, it was called hypersensitive esophagus, the old term and name for reflux hypersensitivity. The two metrics are PSPW, which is the post-reflux swallow-induced peristaltic wave. Normally, we should have a swallow after reflux events. And so the higher the index, the more intact is that response, something we would see in normal subjects or patients with functional esophageal disorder. And so above 61%, an index above 61% will give you functional heartburn, 51% reflux hypersensitivity. MNBI, mean nocturnal baseline impedance, allows us to evaluate mucosal integrity of the esophagus, assessed primarily during sleep time. If it's about 2,292, you've got the functional heartburn patient, and then you can see reflux hypersensitivity, non-erosive reflux disease, and others using the MNBI as a diagnostic criterion. Another way to separate between non-erosive refluxes and functional heartburn is mucosal impedance, which is here a balloon, and on it you have 3 lines of sensors that measure in between them electrical conductivity, and they can assess a spot mucosal impedance. Here is one of the studies using the previous version of the mucosal impedance probe. But if you look, you can see it can separate between patients with pH positive, endoscopy negative, the non-erosive reflux disease, and pH negative, endoscopy negative, the functional heartburn or reflux hypersensitivity patients. Okay, so how do we treat functional heartburn? This is based on the AGE clinical practice update. PPIs have no therapeutic value in functional heartburn, the exception being proven GERD that overlaps with functional heartburn. Neuromodulators, including tricyclic antidepressants, selective serotonin reuptake inhibitors, testosterone and histamine 2 receptor antagonists, can be used as primary therapy in functional heartburn or as add-on therapy in functional heartburn and overlaps with proven gastroesophageal reflux disease. Acupuncture and hypnotherapy may have a role as sole treatment of functional heartburn or in conjunction with another therapeutic modality. And anti-reflux surgery and endoscopic GERD treatment modalities have no therapeutic role in functional heartburn. Here are, this is a table that looked at randomized controlled trials using neuromodulators in functional heartburn. The 2 green lines are positive study. The orange one, actually, it's a negative study using imipramine. We can, if you have questions about that study, I'll be happy to answer during the Q&A. Fluoxetine and ranitidine have been shown to improve symptoms in patients with functional heartburn. Ranitidine as a neuromodulator, not as an anti-reflux medication. Here's a study showing testosterone. It's a 5-HT4 agonist, a selective 5-HT4 agonist that has been shown to increase perception threshold for pain in patients undergoing balloon distension in their esophagus. This is a study showing the value of fluoxetine and SSRI in patients who failed omeprazole once a day. This is a study randomizing patients to melatonin or triptyline and placebo, demonstrating that melatonin was able to improve symptoms in these patients. And this is a study looking at hypnotherapy. We don't have many studies in this patient population using psychological intervention, but this small study, hypnotherapy, open label, 9 patients, but did show improvement of patients' symptoms, those that underwent 7 weekly sessions of hypnotherapy. What about treatment guidelines for reflux hypersensitivity? PPIs have a therapeutic value in reflux hypersensitivity, regardless if it overlaps with GERD. Neuromodulators, including tricyclic antidepressants and selective serotonin reuptake inhibitors, can be used as primary therapy in reflux hypersensitivity or as add-on therapy in reflux hypersensitivity that overlaps with proven GERD. Acupuncture and hypnotherapy may also have a role in treating reflux hypersensitivity as sole treatment or in conjunction with other therapeutic modality. And the last one, the data support that, but I would be very cautious. There is some data suggesting that anti-reflux surgery, but not endoscopic GERD treatment modalities, may have a therapeutic role in carefully selected reflux hypersensitivity patients. This is a study actually showing the value of PPI in patients with reflux hypersensitivity and as compared to functional heartburn. What it did is show in this study any value. This is a study showing that Nissen fund application can improve symptoms in patients with reflux hypersensitivity. In fact, the title of this study, of this paper, is Reflux Hypersensitivity is not contraindicated in Nissen fund application. However, as I mentioned, I would be very careful in considering a functional esophageal disorder patient as a candidate for surgery. Going back to this table that looks at randomized controlled trials of neuromodulators in functional esophageal disorders, the orange one is the negative study using imipramine, was also looked at patient with reflux hypersensitivity. The green one, citalopram and fluoxetine, who demonstrated positive response to these medications in patients with reflux hypersensitivity. This is a study that we've done, and we actually randomized patients who failed PPI once a day to add-on acupuncture or double dose PPI, and the add-on acupuncture arm did better than the double dose PPI, suggesting that acupuncture may be helpful in both functional heartburn and reflux hypersensitivity as an add-on therapy and potentially as a sole therapy. And as I mentioned, always remember the role of psychological intervention. In both of these functional esophageal disorders, psychological intervention may help these patients, usually not as a sole therapy, but as part of a comprehensive approach to these patients. And those may include cognitive behavioral therapy, hypnotherapy, mindfulness, and others that are mentioned on the slide. Now, I'd like to, again, emphasize that in some of these patients with GERD and an overlap, if their overlap is with reflux hypersensitivity, then add to PPI treatment what is mentioned here on the slide, like baclofen, neuromodulators, psychological intervention, or alternative and complementary medicine. In those that have an overlap with functional heartburn, add to PPI treatment, because these patients have known GERD, neuromodulator, psychological intervention, or alternative or complementary medicine approach. Thank you very much. And Bradley, it's yours.
Thanks, Ronnie, for that fantastic presentation. Really covered all the areas in great detail. So thank you so much for that. I would like to remind our audience just to feel free to ask questions using the Q&A function. We would really encourage you to be engaged. I know you were captivated by Ronnie's presentation, but if you do get time to ask questions, that will certainly help with the last part of the session.